All right, thanks, Tracy. First of all, I want to say thank you to Dr. Long and Dr. Roney for actually coming through this journey with me on this project. I met Dr. Roney roughly about a year and a half ago during my undergraduate, and was talking about thymine infusion and stuff. Talking about Wernicke's encephalopathy. The reason Wernicke's encephalopathy hit home with me was back in 2016, roughly in July, I had a patient that was presenting with symptoms of Wernicke's encephalopathy. Family members kept on calling and kept on addressing, it's like, this is what I need to diagnose them with, and the physicians weren't listening. Tried to get the family members and the physicians to communicate, and there was just always a lack of communication right there. On my third day, trying to get them to communicate, we finally got them in contact with each other, and we were able to actually get the patient diagnosed with Wernicke's encephalopathy. At that point, it was already too late, and he actually developed Korsakoff's, which we'll actually discuss that here in a minute, which is actually irreversible, and it's a lifelong term disease that he's going to live with. So again, my topic is going to be staff awareness of Wernicke's encephalopathy. So what is Wernicke's encephalopathy? Wernicke's encephalopathy is a neuropsychiatric disorder which arises as a result of thymine deficiency. It is a condition frequently associated with alcohol misuse and has a high morbidity and mortality. In 80% of the cases, the diagnosis is not made clinically prior to the autopsy, and inadequate treatment can leave the patient with permanent brain damage, which is also known as Korsakoff syndrome. Thymine, which is the main factor of what actually causes Wernicke's encephalopathy. So thymine is the essential cofactor for enzymes in the pentose phosphate and Krebs cycles, and the brain heavily relies on the glucose metabolism and thymine in order to function optimally. Thymine deficiency lasting for over 4 days results in neurotoxic edema and a biochemical cascade of insufficient metabolism and oxidative stress. Certain brain structures are vulnerable to damage resulting from thymine deficiency, including the thalamus, mammillary bodies, paraventricular areas, locus coeruleus, cranial nerves, nuclei, and reticular formation. So often people ask who's at risk. The huge population that actually, based on the literature, the biggest population is going to be the alcohol users. Roughly about 80% of alcohol users or abusers will actually be diagnosed with Wernicke's encephalopathy. Other patients who are actually at risk will be Alzheimer's patients, severe obesity patients. Usually when they go through gastric bypass and stuff, due to the malnutrition stuff, they're actually at higher risk of having the thymine deficiency on that aspect. Elderly patients who don't usually eat and stuff, they're malnourished, and they're actually at higher risk for Wernicke's. Patients with schizophrenia, DKA, patients with AIDS, usually female patients who are pregnant and have the hyperemesis gravida, anorexia nervosa, patients who have cancer, sepsis, and also patients with tuberculosis. Other literature says that patients who have chronic kidney disease are at risk as well. So some of the literature findings that I was able to find, I put some little statistics up here on that aspect. So Wernicke's encephalopathy is, like I said, is a neuropsychiatric emergency with a high morbidity of about 84% and a mortality up to 20% if we don't get this treated and diagnosed early. Wernicke's encephalopathy is readily reversible if treated with adequate doses of peritoneal thymine, preferably within the first 48 to 72 hours of the onset of symptoms. Clinical diagnosis of Wernicke's encephalopathy is missed in 75 to 80% of the cases as the classic triad of ataxia, ISUNS, which is nystagmus or the gaze, and altered mental status. So it's very hard to diagnose patients with this because these different signs and symptoms can go with other disease processes such as head injury, sepsis, if you're actually coming off benzo withdrawals, if you got any type of alcohol withdrawals as well. So it's very, very, very hard to actually screen these patients and stuff. So again, there's a whole purpose of this study was to actually try to find a way to actually screen these patients and actually try to get the treatment started at a very early state. Also, again, 80 to 85% of the patients who do survive develop a chronic disorder of severe memory deficits with amnestic states that include learning deficits and short-term memory loss. There is no simple blood test to detect Wernicke's encephalopathy. The diagnosis, again, is based on the symptoms that is presented. In a study that was noted by Thompson, Marshall, and Bell, noted that 18.6% showed no symptoms, 37.1 showed one symptoms, which could have been either the nystagmus, ataxia, or the delirium. 27.8% showed that they had two signs, and 16.5% showed the three signs, which is also known as the classic triad. Also, with the literature that I was reading and stuff, they were actually wanting us to go ahead and treat patients if they actually have two triggers and stuff. So if they're presenting with delirium and ataxia, they want us to go ahead and do treatment. They want to go ahead and start treatment for risk of Wernicke's encephalopathy. You can't actually diagnose Wernicke's if you don't have all three symptoms presenting. So the purpose of the study was to ensure that Covenant Health has an increasing awareness of this serious misdiagnosed disease that can be easily treatable. I want to collaborate with other healthcare teams to ensure the proper treatment for these patients. And I also want to discuss screening tools and assessments to screen for this high-risk population. So this project actually came into three different phases. Came into phase one, which I did my IRR back in summer of 2017, and then also did another IRR spring of this year. So when I actually did my IRRs, which is an integrated research review, the questions I posed at that time for my very first one was, does the implementation of a thiamine protocol in the early treatments of Wernicke's encephalopathy decrease the incidence of a neuropsychiatric syndrome in the acute care facility? And then my second IRR was going to be, can alcohol assessment screening tools be modified to more accurately identify patients with thiamine deficiency to reduce Wernicke's encephalopathy? Again, here's one of my posters. This is going to be from my first integrated research review. You can see my methodology that I used, the results, and then the literature synthesis. So the background that was noted on this, again, it talks about the Wernicke's encephalopathy, but in the literature that with this one, it says thiamine deficiency was unknown and the patients left without treatment died after a mean of 6 days of hospitalization. So phase two was going to be my second IR, which I did this spring of 2018. This one was, can alcohol assessment screening tools be modified to more accurately identify the patients with thiamine deficiency to reduce the Wernicke's encephalopathy? The background on this one was a recent review showed that a recent review of the use of the most common symptom trigger treatment tool, also known as the CWA protocol, revealed that it was used inappropriately in 50% of the cases. That is a very, very large amount of cases that we're missing. The significance I found in the literature was it is essential to consider the diagnosis of Wernicke's encephalopathy in any confused dependent patient attending the acute care hospital. Also, I noted a case study was reviewed and it performed thiamine infusions with clients who were diagnosed with 3 different types of cancers that were at risk for Wernicke's. Each client was given high doses of thiamine infusion, which was 500 milligrams of thiamine, and they actually got it 3 times a day for 2 days. And with their study, they showed that they had a rapid reversal of altered mental status. Again, like I said, I did 2 IRs, and then this is what led me to do my IRB. And I did get the approval for the descriptive retrospective chart review. I was able to perform my review studies from the databases. I did look in Sinhall, Cochrane, Medline, and PubMed. When I actually did my descriptive chart review, I was able to obtain 1,515 charts that were actually coming from Covenant from Lubbock's campus. That didn't include California's campuses at all. So when I actually got the charts, they were all coded for encephalopathies. But when you're actually looking at the codes, they actually coded each encephalopathy different. And when I actually submitted for my IRB, I submitted for a code G92, which was toxins related to encephalopathy, which could have been metals, it could have been medications, it could have been alcohol, anything that was toxin related that would actually cause. And I figured that would have been more so related to the Wernicke's, because if you look at the G93.40 and stuff, that was like hepatic encephalopathy. G93.41 was just a regular unknown encephalopathy, and then the codes would go on further. Out of that 1,515 charts, 222 charts were coded with G92, and 35 charts actually met criteria for the study. So with the literature finding and stuff, to actually treat Wernicke's encephalopathy, there is different actual literature findings that was noted. A few that I was kind of referring to was a physician, a Royal College of Physicians, and their actually regimen calls for 500 milligrams of intravenous thiamine 3 times daily for 2 to 3 days, with 250 milligrams intravenous thiamine for the next 2 to 3 days. And then they're going to follow that with an oral thiamine supplementation indefinitely, which would be roughly about 100 milligrams daily. So after I was able to get my IRB approval, these were some of my certifications. This one's going to be from St. Joseph's IRB, and then this one over here is going to be from LCU's approval. So with the clinical findings, again, I was able to extract 35 charts, and they actually met criteria. Well, we extracted 222 charts, but 35 actually met criteria. So with the clinical findings, the minimum age that I was noted in this descriptive study was 19. The maximum age was going to be 73. And the range age was going to be 54. And the mean statistics was going to be 47.94. So you can see that there was a huge range between the youngest and the maximum age in this study. Out of the 35, 68.6 or 24 of the patients identified as males, and 31.4 or 11 of them identified as females. This is where it kind of got a little tricky when I was actually looking at my clinical findings and stuff. And when we get to the next slide, and I'm going to point out why it kind of seems like it's a little off, and based on what I noted and stuff, and I explained why it could be off just a tad bit. But out of the 35, 29, or 82.9% or 29 of the patients identified say that they did use alcohol, and 17.1% or 6 of them said that they did not have any type of alcohol use. So remember that 6. So if you come over here, you look at the bottom, and there's 5. So you're thinking 5 of them, 6 previously said they didn't have any history, but there's only 5 over here. So what was noted on this part was they were telling the nurses on their admission assessment they didn't have any type of alcohol use, but when I was actually looking at the charting and stuff and looking at the physician, it was noted that the physician was catching the alcohol use in their assessment findings on that part. So out of the alcohol choices, 37.1 said that they actually drank beer. 34.3% or 12 of them said that they actually drink liquor. 14.3% or 5 of the patients said that they actually did beer and liquor. So also with this, when we're actually doing some of the intake and stuff, I noticed when we're doing our admission assessment, with Meditech and stuff, when we're actually looking at it, it says substance abuse, it says ETOH, substance abuse, and you can actually click ETOH, and then it asks if they're a daily user, a weekly user, a monthly user, but it doesn't ever identify the amount that they actually use. So that was another thing that was kind of noted too. I think we kind of need to fix with our charting and admission assessment as well. It was noted that some of the physicians were saying that they were drinking a pint of liquor a day. Another one was saying they were drinking a 12-pack a day, 6-pack a day, but nowhere in our admission assessment, as far as nurses, has a spot where we can actually identify how much they're actually drinking. Sometimes, if we catch it, I think that's a very valuable information so that the physician can actually see that. So I think we need to modify our admission intake on that aspect. With this, when they actually got admitted to the hospital or to the floor, 37.1% or 13 of the patients did not get any type of thymine. 62.9% or 22 of the patients did get thymine infusion. And out of that, usually the thymine that was ordered was 100 milligrams, and it was usually 100 milligrams once a day IV. There was one case where it was 100 milligrams and they were getting it 3 times a day, but it never was kind of correlating to the current literature that I was reading up on, where it was saying 500 milligrams TID, and then we go to 250 milligrams TID. Alcohol screening completed in the EMR. So this is when we actually got to the actual floor from the ER. When we actually got to the floor, it was noted that out of the 35 patients, that 10 of them, the alcohol screening was never done. So we're missing that when we're actually getting to the floor, the nurses at the bedside are not doing this admission screening, so we're missing it. They're either not doing it, or they're simply just not doing it, or they're just kind of going over it. I think it's just, again, when I'm looking at some previous ones, I noticed that some of the nurses, when some of these patients had multiple admissions, it was noted that one nurse would say that they had a history of alcohol abuse, another nurse would say that they didn't, another nurse wasn't even doing the admission assessment. So we're having a glitch when we're actually getting to the floor as well, and why we're actually. So I'm trying to figure out why we're missing it when there's actually an HMP coming from the ER, and also when the ER nurses are telling us that they have a history of EATOH as well. But yet we're not actually documenting it in our admission assessment once we get to the floor. 71.4% or 25% actually had their alcohol screening completed on the admission assessment. So when they actually get admitted to the floor, I was looking at some of the protocols that they were actually using for these patients. Some of them were just going to the floor. They were just being treated for just encephalopathy, and so they weren't even, they didn't have any type of protocol or order or anything. They were just doing treatment as far as lactulose. So only 2 patients, or 5.7%, did not have any type of protocol. They were just being treated with lactulose. 2.9 or 1% was actually admitted, and they were using the sepsis protocol. 51.4%, or 18 of them, were actually being admitted, and they were actually using the CEWA protocol. 37.1, or 13 of the patients were only doing the delirium CAM ICU, and also noted that there was actually some documentation that wasn't actually documented properly on that, and I think that's more of an education thing as well. And I brought this up with Dr. Roney as well. I've been at Covenant roughly about 11 months now, and I'm still trying to learn that one, and so I think it's just more of an education issue on that aspect. And then 1 or 2.9% were coming in, and they're actually using the CEWA and the sepsis protocol. So we're looking at the hospital days that they're actually in the hospital, and there's a wide range. Some patients were there for 1 day, and I'm not going to go through all the days and stuff, but the longest hospital stay was for 28 days. It looks like the most that they're actually staying in the hospital was roughly about 4 to 5 days, even 3 days. There were about 7 patients staying for 3 days out of the 35. 4 patients were there for 4 days out of the 35, and then 6 patients were there for 5 days out of the 35. So they also looked at the ICU hospital days as well. Again, because I was kind of looking at some of the cost factors as well on this aspect. 9 of the patients didn't even come to ICU. They went to a regular med-surg floor, either a telemetry or a med-surg floor. See, so the hospital days, it looks like most of them were there for either 2, 3, or 4 days were the highest days that they were actually in the hospital. And then after that, they were either transferred to the floor. There was actually 2 when I noted that were actually discharged right from the ICU, and I think that was just because we were a shortage of beds that they couldn't actually transfer to the floor. So Wernicke's symptoms. So again, to be diagnosed with Wernicke's, you do have to present with different types of symptoms. You had to have the delirium, you had to have the ataxia, which is kind of the shuffling, unsteady gaits with the feet, and he also had to have the nystagmus or that gaze. So with this, out of the 35, 8.6 or 3 of the patients did not have any type of symptoms. 11.4% or 4 of the patients did present with ataxia. 28.6% or 40, that's wrong, I need to fix that. So 28.6% did present with delirium. 2.9% or 1 patient did present with nystagmus. 34.3% or 12 did present with 2, which was going to be ataxia and delirium. And then 5.7 or 2 of the patients did identify with delirium and nystagmus. And then 8.6 or 3 of the patients did identify with ataxia, delirium, and nystagmus. So I was kind of noted on this as well when I was looking at the charting as well. In ICU, the charting is kind of, when we're doing our neuro assessment, it's very hard to figure out where you can actually chart nystagmus. I've been there for about 7 months, and I didn't realize that there was actually a button for nystagmus. So again, I think it's just a learning. When we're doing Meditech training and stuff, I don't think we're going, I'm not saying that we're not going through the proper trainings or anything like that, but there's some issues where we kind of need to explore with Meditech. When I was looking at the med surg floor, when you actually do the neuro assessment, it's funny because when you're actually looking at the ICU, when you actually look at the eye symptoms and stuff, it actually shows nystagmus. When we actually get to the floor, when you actually try to look at that, it doesn't even give you an option for nystagmus. So it's I'm not sure why it would show in the ICU that they can have nystagmus, but on the floor it doesn't have any type of nystagmus that you can actually click. So out of this, again, to be diagnosed with Wernickes Encephalopathy, you do have to have 3 of the factors. And so 91.4% or 32 of the patients did not have all 3 of them, but 3 of the patients, or 8.6%, did identify with all 3 symptoms. So with that in mind, how many were diagnosed with Wernickes Encephalopathy? None of them were diagnosed with it. When I was reading the literature, it was noted that many of the physicians and even the staff nurses at the bedside are unaware about this disease. When I was actually looking at this, only 1 patient out of there who was being followed by a psychiatric doctor noted that there was a possibility of Wernickes encephalopathy, but they weren't doing the high doses of thiamine. Other than that, out of the, like I said, 35, none of them are actually diagnosed. So that's where I'm trying to figure out where's the issue. Is it just a lack of information about this disease process? And so hopefully after this and coming to Research Council and presenting this to at Covenant stuff, maybe we can get the awareness out there. And I'm not saying we're going to have to diagnose every patient with Wernicke's encephalopathy. That is not my goal or intentions by any means. But I want to go ahead and try to make physicians aware, even the staff aware, that these patients are at risk. So if they're presenting, especially these elderly patients who come in confused, let's go ahead and start some type of regimen. Let's go ahead and get them on, because again, looking at the literature and stuff, if they're not at risk, but they have, one of them says if they're presenting with one symptom such as delirium, let's go ahead and start them on peritoneal thiamine, which is going to be 100 milligrams IV daily. So these elderly patients who are coming in malnourished, confused, even these patients who are chronic kidney disease who are confused, it doesn't hurt to go ahead and get them started on just a regimen of 100 milligrams of thiamine daily. Now, if they're presenting 2, again, I'm not saying that they're having Wernicke's, but they're at risk. So let's go ahead and start them on the regimen of 500 milligrams of thiamine 3 times a day for 2 days, and then let's go ahead and cut it down to 250 milligrams for 2 to 3 days, and then we'll go to the 100 milligrams orally after that. The cost, looking at the literature and stuff, the cost to actually prevent Wernicke's, again, because once you actually get to Wernickes Curse, it is irreversible. It is a lifelong they've got to go to a nursing home, they can't go home, so you got to think about the costs. If we don't catch this at early ages and stuff, can you imagine the cost in the long run that they're going to have to be living with, and once if they have to go to a long-term care facility on that aspect. So some of the discussion I want to bring up after finding some of these findings is bedside nurses need to be more cautious with the history assessment. Again, what I noted, one patient, when I was doing this chart review, patient was there, the one that was there for 28 days. The admission assessment wasn't even completed. Like, not one individual did the admission assessment at all. So it makes you wonder, if we would have done that admission assessment, could we actually caught this sooner, and would the outcome have been better on that part? Also, again, if we're not doing the admission assessment, taking a thorough history on the alcohol intake, and again, it's just not alcohol intake. The other patients are at risk for, but again, the biggest population is going to be the alcohol abusers. If we don't do the screening and stuff, and again, some physicians do take the time to look at admission, and if they're aware of this, they can probably start this regimen as this thiamine. Another thing I noted too, and I've been seeing this with some of my colleagues as well, is if the patient is unresponsive, automatically they say patient's unresponsive, and so the admission assessment is already completed, and so we're not getting any type of history on this. So, and I do know that you had to have the admission assessment completed within 24 hours, but I think some part of the admission assessment we need to kind of leave pink. The way we do it at Covenant, it's either pink or it's red, and it's just indicating that it has not been done or completed and stuff. Again, I think some of this history is very, very important. So if we complete it and say a patient is unresponsive, just think when they come out of this, if they're intubated or if they come out of this confusion state and they can answer our questions, it's very important that we get that history assessment with them. So that's one thing I was going to see if we can educate that, maybe do something as far as policy-wise on that. Meditech charting for neuroassessments, again, I noticed that there was a discrepancy between the ICU charting and also the med-surg. When you're looking at when you're assessing the eyes, the ICU can actually document nystagmus, whereas med-surg, you don't even have that option to choose nystagmus. You actually had to probably say other and write it in. EMDs, DOs should assess our patients versus copying assessments. You will not believe what I found. It seems like every assessment that I would see on the providers and stuff, it was almost copy and paste. I brought this up with some of the at Research Council and stuff. None of the assessments changed. It seems like nurses are catching it. When I was looking at some of the signs and symptoms that were presented, some of it was actually being caught with the nurse's assessment, but it was never documented in the physician's assessment. When they were doing the HEENT, which is head, ears, nose, throat, and looking at the eyes and stuff, it says unremarkable or something like that. But I'm like, it's not unremarkable. If you look at the nurse's assessment, they have these findings and stuff, but then yet they're documenting something else over here. So again, we just need to do a better assessment and charting with that. Also, nurses, we need to read H&Ps. When I noticed when we were being admitted, when they were being admitted to the hospital, again, some of the history assessments were saying that they were not had any type of alcohol abuse, but then yet the physician was documenting, yes, they were taking a pint or a six-pack, but then yet we're documenting that they did not have any type of alcohol abuse. Conclusion. So I sat down with Dr. Long and we tried to run analysis on a few things, and we ran different tests through SPSS 25, and it is to me, I think it's a complex program, but it's because I haven't really got my feet wet with it. But after this, we actually did a post hoc analysis and to see if we can explore the data further. We did an ANOVA test, and we assessed the hospital days, dosage of thiamine, and the symptoms related to Wernickes encephalopathy. We assessed the coefficients and the culinary statistics to see if it met the assumptions. Based on that, factorial ANOVA was conducted to compare the main effects of thiamine and the interaction effects between Wernickes Wernicke's symptoms on the hospital, all effects were statistically significant at 0.04. So if you look at statistics, you want it less than 0.05. So we actually met that criteria and stuff. So there is some correlation with thiamine being administered and actually decreasing the side effects of the Wernicke's and actually decreases stay at the hospital as well. So we were able to find that when we actually did this conclusion. If I did not get that correctly, please correct me, Dr. Long. Okay. So, here we go. So we talk again. The statistically significant difference between the hospital days and thiamine infusion as determined by one way. Again, these numbers are a little terrifying stuff, so I had to kind of look at it to do this. But when we ran it, again, maybe Dr. Long can help me. Again, we'll talk about it here in a minute. She can probably help me explain this a little bit more in depth. And it revealed that the adjusted R-square was at 0.131 on that aspect. So before you watch this little video, it's only a minute and a half. It's not very long. I emailed Dr. Long. It's been very busy at work. I did work my 6 days. But I was speaking to Dr. Krushek there at Covenant, and I was telling him that I did 2 IRs and did an IRB and doing this literature review. I had a patient, won't get in very much depth and stuff, came in, was very, very combative, had multiple admissions, was actually just discharged and came back within 3 days. And I was so busy. This patient was, again, 4-point restraints. And so he just kept me a little busy at that moment. And so I was thinking, it's like, again, did my assessment. He had a nystagmus. Wife was saying that he was having falls, his gait's unsteady, there's ataxia, delirium. So I was like, this is Wernicke's. So it reminded me so much of Wernicke's. So talked to Dr. Krushek, said, look, I've done this 2 IRs and this IRB. This current literature is saying that maybe we can do high doses of thiamine and stuff. He was very, very open to it, and we actually did the recommendations. And so had that patient for 2 days, and we did the 500 milligrams TID. And at that time, I can tell it's a significant difference. He was in and out of it as far as mental status, but some of his other symptoms were presenting were actually kind of resolving. When I was talking to Dr. Krushek, though, he says possibly if he's already had it, we're already behind the ball game, and that's probably part of the issue. When we were looking at the H&P, again, he was admitted a week prior to this, and I was so busy and stuff, but it said possible Wernickes encephalopathy. So it made me wonder if he was here at that last hospital stay, if there was a possible, and we did that high dose of thiamine. Was this a result of not having those high doses of thiamine? So it makes you wonder. Again, some of these physicians are saying possible Wernicke's, but we're not doing what the current literature is saying, doing these high doses. So it makes you wonder. Could we actually done the high dosage? Could the outcomes been different for this patient? Because now this patient is probably going to have, again, I left, so I don't know how this patient is doing now, but could this patient's mental status be completely 100% intact? Could his ataxia have been resolved if we actually were intervening sooner and did this regimen of this high dose of thiamine? I am going to, again, play a small video of Wernickes Curse off. And so this is just and again, this individual, this is her father, and she actually writes in her comments and stuff that she posted this for a teaching tool. And unfortunately, her father did pass, but he had Wernicke's. He actually went to detoxing, and he was in ICU for 53 days, and he finally just passed and stuff. But again, the story, I would actually try to get in contact with her to see if they did any type of oral thiamine regimen before he actually went to detoxing, because could that have been prevented if we were actually to do the regimen and stuff. So this is a result if we don't diagnose it at early stages.
Hi, Dan. Hi. How you doing today? Huh? You're having a good day today, huh?
How you doing?
Huh?
How you doing?
Good. I'm doing really good. You look like you're doing really good too.
Colby,
Colby.
I'm Bunny. I'm Bunny.
And Kelsey too?
Yeah. You want that? That's what you want to eat.
What he wants to eat?
Yeah.
You gonna feed him?
Yeah.
That kid doesn't eat anything. Picky, picky.
Colby, what you feeling for supper?
What are you gonna make him?
Huh?
What are you gonna make Colby for supper?
Oh. Or you want to come home first and then come back?
Okay.
Okay?
Say I love you.
I would have
I love you more.
same fun.
That is the long-term effect. So this guy, again, his result was, unfortunately, he did pass. But imagine if he was able to get discharged from the hospital, he would never have been able to go back home. He would probably go, maybe if he had a care provider there at home with him, but other than that, he would have to have 24-hour care and stuff. Again, I'm not, with this, I'm not saying that, well, let's kind of backtrack. So again, high risk are going to be the alcohols, but we need to, again, kind of look at other patients that are at risk as well. Again, we need to look at the elderly who are malnourished, patients who are have a history of cancer. When they go through treatment, they don't want to eat. They just don't feel very well and stuff. So any patient that comes in, what type of cancer or anything like that, again, let's do prophylactic thiamine infusions and stuff to maybe prevent. Another thing too, I'm noticing in the ICU is when we're having them intubated and stuff, most of the time we're not doing tube feedings. All we're doing is IV fluids and stuff. And can you imagine if they've been on the vent for 3 or 4 days, they have not had any type of nutrition whatsoever. So if they're going to be on a vent, maybe more than 1 day or 2 days, I think we should automatically go ahead and start them on a prophylactic thiamine as well, like maybe 100 milligrams as well. Because you think about it, 3 or 4 days, 5 days on a vent, if they don't have any type of TPN, because it seems like we're starting TPN late on some patients, and also tube feedings. We're not dropping NG tubes or OG tubes on them and doing any type of tube feedings on them. So we're already behind the ball game. And again, the same case when I was working back home back in 2016, that patient, I believe, he did leave, and he actually presented like this. He was not able to walk. His mental status was never there and stuff like that. So it makes you wonder if we were to actually do this at a very, very early stage and stuff, we could actually prevent this. So this is the reason why this topic was very special to me. So, and that is it.
Michael, okay. I don't know where to start because you highlighted so many things that are important to us in nursing. I want to start kind of with how I met Michael, though. He was the only undergraduate student presenting a poster together with all of the graduate LCU nursing students. And I immediately was drawn to his topic, and as I talked to him and realized he was the only undergraduate LCU student there that day, it made me a bigger fan because he had such a passion for not only the topic, but for the process and research. And so I was able to see his second poster and was just as passionate. And so I can say you're probably like embody the fact that if you're really passionate about a subject, then it makes it kind of fun to go look for answers and explore. Do you think?
Yes.
I mean, I see that with you. And the other thing I see with Michael's particularly is his first day of new nurse orientation. I talked to all the new nurses that start at Covenant. He immediately found me before I even walked out of the room and said, I want to be on research council. I want to be with you. Okay. And I have a theory about people like you. But for us older nurses, especially somebody like Vern, who's a nurse leader at UMC, and others in the room, is we have nurses today that aren't going to want to work for us if we don't support evidence-based practice. They want to work for an organization that embraces the passion they have for us doing the right thing for the patients. And so we may not relate to every new nurse, but there are those new nurses that I don't think you would stay at Covenant or UMC or any other hospital if you didn't see that we were really working towards evidence-based practice. That being said, okay, now I gotta get into your stuff. Wow. Did you not highlight the gap between evidence and practice? How in the world are we have such a gap in how we should treat a patient population and what we're actually doing for them? I feel like we live this every day as nurses, but to hear that gap and to see it in black and white, it hurts my soul so much, especially when a lot of the initiatives you put up there were my initiatives. The delirium CAM ICU screening, I rolled that out with ICU nurses, and I told them it was an evidence-based practice, and I told them why we were going to do that. And to see that only a few weren't in the ICU, but only 13% had CAM ICU done when we're supposed to be screening every single patient every shift, actually every 4 hours. Let me remember my own policy. It's kind of eye-opening. Obviously, that gap in that just the treatment and the gap in communication, all of those things. And then I want you to help them understand ANOVA. What were you doing when you were testing for ANOVA? I know Dr. Longway helped you. What are you trying to do? Or you have like dependent and independent variables, right?
You do. So my variables were going to be hospital days, and then we're looking at the thiamine infusions, and then we're looking at the symptoms presented with Wernicke's, which have been ataxia, the delirium, and also the nystagmus.
I'm putting you on the spot because I know you know the answers, even though we have our cheat person right here. And so you were looking for a relationship, right?
Yes.
It's a correlation. How amazing is that? But you did some very high-level statistical analysis with Dr. Long together, but that correlation you found was positive. So what does that mean to us?
To us, that if we actually do, because again, we were looking at the thiamine, so when we're actually infusing the thiamine, the symptoms were actually being, what's the proper word? We're being decreased, and then the hospital stays were actually decreasing as well. So, and then you look at it, the costs. If you look at the costs, if you look at the hospital stays, you can look at the ICU. You look at the cost of ICUs a bed compared to a med-surg bed. So if we can get them treated at an early stage versus where they're not in ICU stuff, just imagine what we're saving in the hospital. So.
Oh my gosh, see, I knew he didn't need you to answer that. I forced it out of him. He understands what he found. He found a positive relationship between his variables and Wernicke syndrome, meaning that they are connected, and if we treat Wernicke syndrome, we will essentially be impacting those variables. And so, amazing work, by the way. I don't think we let them ask any questions, though, so you want to open it up for questions? I just had to, like, pick his brain a little bit. And by the way, Elaine and I have been working on that early enteral tube feeding for a while. We had to give each other the look. We actually have it that if a patient is NPO for 24 hours, and this was after 2 years worth of work, by the way, that it's checked in the EMR that they're screened by dietitian for feeding. So when we hear you say that, we just still have work to do. We still have work to do.
I just think if they're going to be intubated, they should have an automatically criteria.
That's part of the ventilator bundles.
And I don't know why we're not doing that.
So hearing all these gaps in our work and what's actually being done is kind of,
It's disturbing.
It is.
it's frustrating. We still got work to do, as always. So I don't know, do y'all have questions for Michael? I think he did an amazing job. He's very passionate.
I have some questions, Michael.
Go.
If I don't want
Bring
to
it,
steal,
Tracy.
You're
I don't
fine.
want to steal
We
the
have,
opportunity, but from others. I have all kinds of questions.
No, that's fine.
I tried to kind of go in order as you were speaking, but just briefly, will you tell us, was this the first time you submitted to an IRB? And if so, can you just tell us about that experience?
So yes, this is my first time to do the IRB. So at the same time, Dr. Ronnie was submitting to IRB, and apparently we submit to IRB, and they're located in California. So I originally submitted it, and they sent me back. I needed to correct a few things. And then I hit bumps during this thing as far as my health-wise and stuff, and so I just kind of parked and just trying to get through a few things and stuff. And then got back with Dr. Long, and we did a phone conference, and we talked about what their expectation was. And Dr. Long had recommended just talk to them, see what they recommend, and that's the best way to to see what they want and they need and stuff. So that actually helped out significantly. We sent it, we did what they requested and stuff. The wording, the wording is very, very, you had to have it very precise. And not only that, before you can actually submit, the process to get to the IRB and stuff, you have to do some training, the city training, which when you actually do it initially, it's about 4 to 5 hours when you actually do it. So it's a lot of training, and what they teach you in that, they teach you how to deal with subjects and talk about ethical issues and just different stuff like that.
So that in itself would have been a huge learning curve.
Yes.
Yeah. Anybody with a question before I ask another? No? I kind of wondered about, because really your information, what you found from the literature as far as the dosages of thiamine is valuable pharmacy information to even pull them on board. And then that may be way too far in advance, but have your thoughts gone in that direction?
It has. So we actually have the intensive program there at Covenant on the 3rd floor. So with the intensive program, they have a physician, they actually have a pharmacy there and stuff. And we're currently in the process of splitting, so I'm going to be on the 4th floor. We don't have that program anymore. So again, this week when I was able to talk to Dr. Khrushchev and give him my information stuff, he was all open about it. And so that, I'm telling you, with me talking to him this week and then presenting, it must have been, I told Dr. Long, like God was just speaking. So, I was able to do this, recommend this treatment and stuff. And pharmacy never questioned, they never said, why are we doing this? And they were okay with it. Because typically, when you send an order that's not your typical and stuff, you usually get, why are we doing this? And so they question you why we're doing this and that. And I never got one question from them whatsoever.
Mm-hmm. So it was smooth as far as being able to implement it for that patient.
Yeah. So usually with this alcohol, so I was kind of thinking, I was going to see if I can find literature with banana bags, because right now our banana bags have I think it's 100 milligrams. And so it's 100 milligrams in a 1,000 cc bag. So if we're doing high doses, and that bag is going to last over 24 hours. Current literature is saying, let's go ahead and give, say 1,500, because it's 500 3 times a day. What if we get that banana bag, because it has all your different elements in it, and so why don't we just go ahead and put 1,500 of the thiamine, because it's going over 24 hours. So why don't we just put the 1,500 and just continue the banana bag then?
Yeah.
So,
Seems like a really easy solution.
yeah.
It does sound easy, huh, Elaine?
Sounds like an easy.
Yes.
No, it really actually could be very easy. How was your conversation with Dr. Khrushchev?
So
Knowing the evidence was
yes.
easier?
So it was a lot easier. And so when I was talking to him, he says previously he had one patient. Again, he had a patient that had developed Wernicke's Curse. It was after 3 days. He told me the patient again, and this is where we're having another issue too. Patients aren't forthcoming with their information at all. He says the patient denied it, and it was 3 days. The patient was full-blown detoxing. Again, we're already behind on our treatment. So, and he developed Korsakoff's. So again, he was, once you get into Korsakoff's, Wernickes Curse, it's irreversible. It's long-term effects. So unfortunately, that patient suffered because we didn't start the treatment early enough. But it wasn't anybody's fault on the medical aspect. It's because we didn't have the information from the patient. It wasn't until that family members came up and said, oh yeah, they do drink this much daily and stuff. So again, I think that's where we're having issues as well. We're doing admissions, and I know we do have to get our admissions assessment done within 24 hours, but oftentimes when our patients are coming in unresponsive, confused, they're not going to give us the proper answers anyways, and so we're clearing out that process on the admission because we're documenting confused, unresponsive, patients tube. Well, let's wait till family gets here. Let's get the information from family and see if we can actually chart that in the assessment as well.
What is your plan on making change?
So a couple of the plans is talk to the pharmacy, tell them with the updated literature on this. So I'm going to talk to you looking at the possible the CAM, the CAM ICU, and looking at maybe kind of alternating it to see a risk. So is a patient malnourished? Is a patient have alcohol? And if yes, do they have one risk? Do they have two risks? And if they do meet our criteria, let's go ahead and start a regimen. Like maybe, again, it takes, like we say, it takes years before you bring things to practice and stuff. So, I don't know.
And do you think nurses are connecting the dots? So to tell y'all, they screen for delirium, they screen for SILA, they have all these individuals screen for sepsis every shift. But I wonder, as you were talking, how many nurses connect the three things together? Because they're all individual nursing assessments that are done daily, if not every shift, every 4 hours. But are they able to even see the relationship between delirium and sepsis, delirium and Wernicke syndrome? I mean, you know what I'm wondering? I wonder if we connect the dots enough.
Again, I guess if we do that CAMU, I guess
Somehow,
if we can.
if we change the triggers or
Yeah.
the protocol somehow.
Mhm.
I would recommend, this is just me personally, presenting to physicians
Mhm.
and advanced practitioners.
That's what I was going to say. Maybe when we do research council, I was going to talk to you about that, see if we can discuss this with
Oh,
physicians.
that'd be good.
Because when I was reading literature, it was a lack of knowledge. Even physicians right now, and if you look at this video and stuff, there was a few comments on there saying that even MDs in the ER are misdiagnosing this until they're being hit with lawsuits. And unfortunately, it's sad. But this is a disease, and when I was looking at some of the literature, when I was looking at the possible Wernicke's and stuff, they were being diagnosed by psychiatric physicians. It wasn't being diagnosed by the hospitalist, it wasn't being diagnosed by, so I think it's a lack of education of a psychiatric disorder.
Well, and that's who wrote out CAM ICU, it was actually an LCU alum who was getting her DNP at Tech, and that was her EVP project. And so it actually came from the world of psychiatry into our critical care area, not from us, which probably should, because if you go to AACN, ACBD, bundle, FGH, and I now, I think. Anyway, it's the alphabet bundle. I mean, that's the D in it, is delirium, and CAM ICU is the way we catch that. So it's interesting that psychiatry is a big part of all of this. Any suggestions from you guys? There's lots of nurse leaders in the room on rolling this out or where to go with this information. I'm looking at you guys. Any advice for Michael?
Dr. Long, would you like to come up and speak at all? Okay, just want to make sure.
Well, thank you. I appreciate you
Thank
coming.
you
Thank you.
for your information and helping all.